And if you look at happy dictionaries, they use the word to mean you're testing methods or procedures on a smaller scale, and you're going to use information to plan something on a larger scale. And the same thing if you go into the dictionary of medical statistics, is you're testing something on the feasibility of methods and procedures, and the goal is simple. If you look at other definitions online, they all seem to have something in common. You're doing a test of something that you plan to do on a larger scale. So even though you're trying different things, whether it's protocols, whether it's any aspects for which you don't have enough information on feasibility, the goal is you're gaining some knowledge or some information which is going to help you to do something on a much larger scale. So what's the current practice of how these issues of pilot studies are approached in practice? You'll often find that the term pilot and feasibility, they're actually used interchangeably. So these studies, therefore, are not reported consistently when the terms are used interchangeably. Various journals actually don't even have policies of how they deal with these things. And we all know that in research, words matter. The issue then becomes, is the word pilot and the word feasibility, do they mean the same thing? And if they do, what it is that they really mean, and if they don't, what's the differences? So many journals don't even have editorial policies of how they handle pilot studies or feasibility studies in general, which is part of the challenge that we are facing. In fact, we've had evidence that some editors have actually forced authors to change their studies into pilot by just adding the word pilot, while in fact they were originally not designed as pilot, nor were they ever designed as feasibilities. And of course, if anybody wants to get published, they comply with whatever the editor is forcing them to do, and that's part of propagating bad practice, which is what we see in the literature. So overall, there's never really clear sense of how well these are reported. In fact, the few reviews that have looked at this issue found that there's too much emphasis on hypothesis testing, which is really never the primary goal of piloting or assessing feasibility. There are no clear feasibility objectives or outcomes, and the analytic plans are never really well described. And there's not even a mention in many of these studies as to whether they're being done to inform the design of future studies. So overall, the message is that the practice is terribly inadequate in terms of how we use the term, whether they mean the same thing or they mean different things, and how we actually go about reporting studies that report results of pilot or feasibility studies. And the editorial policies are all over the place if they ever exist. In many cases, they don't even exist.
All right, I'm going to move over to the next section that I thought was good to highlight.
Typically, we use the term proof of concept for studies that are trying to assess whether a treatment has a biological effect in patients for whom the intervention is actually indicated. So typically this would use surrogate outcomes, and if we can show that actually the concept works, if I'm trying to actually deal with cardiovascular mortality and prevent it, then I could use blood pressure as a surrogate marker of that. And then you can assess whether would this therapy actually work if I'm trying to prevent cardiovascular mortality. Now, you could show that the concept works, but doesn't necessarily mean that the main study addressing protection of cardiovascular death would actually be feasible. And typically, such studies would tend to require a lot of patients. So proving a concept is not the same thing as proving that a study is feasible. So typically, when we are proving, we're trying to assess whether something is feasible, it means at some point we want to go back and check whether we've been successful or we have failed to show feasibility. And therefore, one of the potential outcomes of such a study is you could actually say, hey, we should stop. We're not going to be able to actually do the main study because the results we have show that it would not be feasible. Or it may actually be feasible, but we may have to change a few things. to make it more feasible or more practical. So there's a few things that you need to do. So having some criteria which really are guiding principles to be able to help you to do that, it's helpful. Now, realize that we do actually have the criteria for stopping even in the main trial. Typically, we're trying to achieve the minimum clinically important effect, and that's really when we know we'll be successful. In the same way, you need some criteria a priori to be able to assess whether your feasibility assessment has been successful. Now, if you look at the literature, many of the studies really tend to neglect this aspect, and therefore it makes it even harder to interpret the results in terms of feasibility. How do we know that this were objectively done? This is one of the examples of the trials we did. We said, well, we would actually declare this feasible if we can achieve over 80% compliance to this assessment tool. So we had a priori criteria for determining feasibility. The same thing in the VITALS trial, we had criteria for assessing success on different aspects of what we are assessing for feasibility. And in this trial, this was done by some of my colleagues at McMaster, led by Deborah Cook and Donnie Arnold, and they had criteria for assessing whether it would be feasible to actually move on to the main trial. Unfortunately, there's a lot of misconceptions about pilot or feasibility studies or trials in general. And one of the misconceptions is that is the study that can be completed very quickly. And we all know that that's not really what defines a pilot or feasibility. So you often have trainees given these studies by their mentors or supervisors, and they often will call them, you go do a pilot, and typically they don't do a good job because they think a small study defines a pilot. A study that does not require funding, and we've had excuses such as, I don't have any funding to do a big study, or my boss told me to do this one, and they call it a pilot because of those reasons. A small study that has limited funding, we've had excuses such, I have funding for only 10 patients, or for limited seed funding, and therefore I will call it a pilot or a feasibility study. So these are some of the misconceptions that I've come across. A single center study, I don't have the resources for a multi-center study. So-and-so did a similar study, and they got statistical significance. Ours uses 12 patients, which is double the size, and therefore we'll still call it a pilot. We did a similar study before and got it published. Typically, these are unfortunate excuses which are really mischaracterizing what a pilot or a feasibility study is. Bear in mind that really it derives its name from the goal of assessing feasibility.
All right, and at this point, I'm going to move over to some descriptions of the overarching framework for pilot and feasibility studies. I think a key message from the last block is that just because it's small doesn't mean it's easier. And we found that again and again, that smaller studies need to be designed with great care so they can help inform the larger studies and whether larger studies should be done.
The trials. And when we started, we had a very, large landscape. We could start with, pilot studies or feasibility studies for non-randomized studies. Some are randomized. So we really had a wide spectrum, and we were advised when we had the consensus meeting that perhaps it's best to narrow it down to just randomized controlled trials. So our conceptual framework then was narrowed down. Instead of actually having it linear, rather, we should make it more cyclic, which is really how the research happens, but focus more on the one for randomized controlled trials. So our framework changed to say, when you have uncertainty about the main studies, you could do small non-randomized studies to actually assess other aspects of feasibility where randomization may not actually be necessary. Or you can actually then do a smaller part which is randomized, which really mimics what the main study will look like. Or you could do what we call an internal pilot, where you're trying to assess something at the beginning, but those patients still become part of the main trial. So the concept, our framework actually changed. And as a result of this conceptual thinking, we then went around to different stakeholders and say, how would one therefore define what a feasibility study is and what a pilot study is? So within this conceptual framework, we realized that all the works that you do in assessing feasibility could actually be called feasibility studies. Some of them would be randomized, some of them may not be randomized. However, if you do assessment of feasibility on a smaller scale using exactly the same design as the main study, that would be called a pilot. And there seemed to be consensus from different stakeholders when we went to various professional meetings trying to gauge people's opinion on this. We therefore then...
So this is relevant to some of the process that led to the development of the consort extension on randomized pilot and feasibility studies, which also has a lot of good, a very good framework even for some non-randomized pilot studies, but it is oriented towards the randomized study. And then I'm going to, this is the last block where we go through some of the key messages.
So what's the key message? Really doing piloting is essential because that's where we get an opportunity to assess feasibility. And this is really the best way of assessing whether we would be successful in doing the main study. And you're really trying to explore things that you're uncertain about before you embark on a larger scale. They should be well designed with very clear feasibility objectives, with a very clear rationale as to why there needs to be piloting or assessment of feasibility before you go to the main study. In other words, they need to really be presented in the context of what is it that we are uncertain about regarding the implementation of the main study. They need to have clear analytic plans and criteria for assessing success of feasibility. If we are to use information for sample size calculation for the main trial, we need to acknowledge the imprecise nature of that information by doing a sample size table rather. They certainly need to be registered and they need to be approached with the same rigor in terms of getting them out into the literature and for the public to see. Remember that really a pilot is not a small single center study. It is not a small study similar to somebody else's study. And it's certainly not a study intended to demonstrate the effectiveness of an intervention, because that's really not the primary focus. Now, people who know where Ghana is, somewhere in West Africa, there's a proverb from the Ashanti people who says, you never test the depth of a river with both feet. And the reason is simple. If you did that, you would actually drown. So you can think of a pilot really as a way for us to test the water, see how deep the river is, and which parts of that river would be easy to cross to get to the other side so that we don't drown all the resources for the main study.
All right, so with that, that's the review portion of our webinar here. At this point, I want to just hand it back to Dr. Thabane if he had some additional points to add. And at this point also, for those of you who are on the call, you can start putting additional questions into the chat box over there. We do have some additional ideas for some areas to discuss, and perhaps even a picture of a river that I chose not to wade into today. So Dr. Thabane, are you there?
Yes, I'm here, Will. Thank you.
Great.
That was a fantastic summary, by the way.
Well, thank you.
I'm not sure if I have anything specific to add. I think a lot of things may come up as we go through discussions. Is it possible for me to share my screen?
I think so.
I do have a button at the bottom, but I wasn't sure whether I have the privilege to share my screen.
I think Joy should be able to, I think, grant that potentially. unless we're only allowed to grant it to 2 people.
Try now, Dr. Thabane.
Do you want me to try it?
Yeah, I
Okay.
enabled it so everyone can share.
All right. Can everybody see my screen, I suppose?
Yes.
Oh, that's fantastic. Now, I had sent this point to Joy for us to think about. I think part of what you've gone through in the video is a good sense of whether a pilot and a feasibility are the same or they're different. I have to give a talk next week to another group, and the focus of the talk is really trying to tell the difference between a pilot and a feasibility study. And the reason why this is essential is because we continue to see in practice confusion between the two. So it may be one of the things we want to go a little deeper, perhaps with examples of how to tell them apart. We also talked briefly about proof of concept studies. Those are the ones using surrogate outcomes. Is it something you want to go a little deeper to see whether, would there ever be a chance where a study using surrogate outcomes would be considered some pilot studies, bearing in mind that you know, issues of proving the concept, assessing feasibility, phase 1 studies, phase 2 studies, they are all forms or different forms of pre-studies. I'm using the word pre-studies in code because they tend to be done prior to phase 3 trials where we are trying to get definitive information about whether something does more good than harm. The third thing I wanted you guys to think about is, you know, how concrete should the aspiration of the main study be for something to be really called a pilot? It's often the case that when we have opportunities to do something, and we'll say, all right, why don't we do a pilot? But while there's a suggestion that there's a need to do the main study, but clearly the team putting together the pilot doesn't seem to be committed to that goal, but they see the need. So there has been some discussion, should they be calling their study a pilot, while in fact, even though they see the need, they don't themselves intend to do it. Lastly is, can one really just do a pilot trial with the vague hope that somebody else would actually do it, not themselves? So those are some of the things to which, you know, we may not have concrete answers, but I'm sure everybody has their own take, knowing what the goal is for pilot or feasibility studies in terms of how to approach this. And we can discuss any other questions that you have, but I thought I should throw up these questions right from the beginning to keep in mind, and we can come back to them as we go through the discussions.
I think one of the questions that's emerging over from the chat box is kind of selecting a sample size and how you use that, how you may use information from a feasibility study to inform the sample size of the future trial, sort of do's and don'ts.
All right.
Yes.
So let's start with, you know, can we use information from a pilot study to help design the sample size for the main study? The answer is yes. In fact, one of the key reasons why a pilot may be done is simply to be able to generate some information on the outcomes to be used in the main trial. So while the primary goal is still to assess feasibility, one of the key goals could be, we don't really have any information whatsoever on this outcome that's going to be the primary outcome of the main trial. The unfortunate reality is that by nature, pilot studies would not have been designed with that outcome as a primary outcome, and therefore they may not have been used. And because of that situation, You may have a pilot study not being a very large study, large enough to provide you precise information on estimate of effects on those outcomes and the precision of those estimates. Therefore, if that information is to be used to determine the sample size, one has to then approach it in a way that acknowledges the prevailing uncertainty as captured by the imprecision of those estimates. And the best way to acknowledge that is, instead of calculating a single value for the sample size, calculate a table across the spectrum of the values you're getting from the pilot. And how do you determine that spectrum? You would have an estimate with a very wide confidence interval, and therefore you're trying to estimate the sample size for the spectrum of the estimate across that confidence interval. And similarly, you could also acknowledge the same thing for your estimate of the variance. Providing a sample size table acknowledges the fact that you're using information that's very imprecise, and the best way to do science is to always acknowledge limitations in how we do things. And therefore, yes, a sample size can be calculated using information from a pilot, but you need to appropriately acknowledge the imprecise nature of the information by using a sample size table rather than a single value. Yes, of course, you can go into that table and choose the value that you need, but certainly by acknowledging it with a table tells the reviewers and all the other investigators that we're not claiming that the information we have from a pilot is solid enough and precise enough for us to rely on it fully.
And I think that's a great point. And I mean, I think we could do an entire, well, we could probably talk for an infinite amount of time in terms of determining the minimal scientifically or clinically important difference for a follow-up or main trial. But I think one of the key takeaways here is that, you know, coming up with a point estimate for what that is from a pilot trial is not a good idea. Interestingly, one of the trials I mentioned last time, 2 weeks ago, that we have an ongoing trial looking at text messaging for hypertension and Flint. We even got feedback from a study section as to, you know, we saw perhaps a reduction in blood pressure of about 10 millimeters of mercury in our intervention group in our pilot. And we even were asked from the study section, one of the questions were, why don't you just use that for your sample size for the follow-up study, which we oriented our, you know, clinically significant difference for change in blood pressure to what had been found in larger meta-analyses as associated with reduction in cardiovascular mortality. So that idea of the, you know, yoking it to, you know, this is, you know, I observed, but the confidence interval on my reduction was from 1 to 16 in terms of millimeters of mercury reduction in systolic blood pressure. So we didn't do a table approach, but we chose to look for a 2 to 3 millimeter reduction in the follow-up study. So we were nice about it, as one always should be when we're responding to reviewers, but we did explain to them that we chose not to go for that point estimate because we didn't feel that would be the most likely. You know, we would be sad to miss lower reductions in blood pressure over the course of 3 months than 10 millimeters of mercury. We would think that mostly we were seeing regression to the mean in cases like that. I think one question that actually comes up a lot in our course, and if others want to chime in, if you want to pop your name in the chat box, and you can potentially unmute yourselves, but if everybody unmutes, we've given everybody a lot of power in this, so everybody could unmute themselves. But Dr. Thabane, I'm very interested in what you think about some of the challenges of doing feasibility studies for rare diseases, where you may have to really start in the multi-center space because there's just so few patients with the disease, but it's important to answer fundamental questions, perhaps even how many people are out there who could enroll in the trial.
Yeah. Thanks. Thanks, Will. Actually, Brian also had a similar question related to pilot or feasibility studies in rare diseases. Now, let's think about the framework. The framework is feasibility studies are all types of studies looking at the concept of would it be feasible to do A, B, C, D? And they don't really need to have the same design as the main trial. If the main trial is going to be multi-center simply by the nature of the question you're looking at, which is typical of all rare disease conditions, we have to rely on multi-centers or multi-country in many cases to be able to get it done. You may not want to start with a pilot that has the same replica as the main study. You may choose to say, all right, we'll do with feasibility start in one center. Can we get the patients? And if you are able to actually get the patients in one center and look what the issue is, then scale it up to the next center. And then scale up to 5 centers to see where the issues are. So it all depends on what it is that is most difficult to deal with in the context of how the main study will look like. And I often say for multi-center studies or multi-countries, it's best to start with one country, then scale up to 2 countries or 3 countries, see where the issues are. And for those countries, you may not necessarily start with the same design as the main study. Let's say, for instance, yes, you're worried about recruitment, but it's also an issue of we get the people, could we deliver the intervention? So it may just be a single arm feasibility study and trying to see whether if we took 1 patient in one center or 3 patients in one center, can we deliver them? First, can we get them? And can we deliver the intervention? And can we get the outcomes? What if we still going with a single arm study, but now we have 2 centers? Can we be able to then get those patients in, deliver the intervention, knowing that perhaps in some cases it's not the same individuals delivering the intervention? So all these things can help us learn something where now when we scale it up to make it a pilot, which is a replica of the main study where now we are doing the randomization, that at least we have learned something about whether recruitment in itself can work. And if you move from 1 center, it will actually be done, and move to 3 centers and then implementation and so on. Everything is context specific, and you really have to be thoughtful about what it is that we're really suffering for lack of information, and how can we best approach it in a way that allows us to learn and then take the lessons to go to the next phase, take the lessons to go to the 4th phase, and so on. I mean, the reason why we don't just jump from thinking of an idea to a phase 3 trial is simply because we're trying to avoid making mistakes. And the idea of feasibility is to help you to avoid making big mistakes, because it's incredibly costly when you're running trials to make mistakes.
I think there's also some questions about how to size the feasibility or pilot study itself. And I think I can go through a brief example. First, I will show, this is the river that I did not jump into with any feet because I didn't want to get my feet wet. But this is by my house. It's rained a lot in Michigan. So in terms of the feasibility study that I did, looking at hypertension treatment in the emergency department, in this pilot / feasibility study, we enrolled patients in the emergency department and gave them a blood pressure cuff, and then we had them take it home and text us back their blood pressures over a 3-week period. And then if they actually did that and were still hypertensive, we enrolled them we randomized them to an intervention, which was either to get motivational text messages or to not get motivational text messages. And the main endpoint we were looking at was basically the yield of our blood pressure cuff screening process. So how many blood pressure cuffs did we have to hand out? What would be economical in terms of research staff, and what would be economical in terms of purchasing blood pressure cuffs? So we came up with a bar that we set that was a quantitative bar, but everybody on this call could argue that it was an arbitrary bar, in that we were planning to enroll approximately 100 patients. And we looked at what would be a 95% confidence interval around 33%. We figured if we were giving out 2 blood pressure cuffs for each person who actually responded to us and was still hypertensive, because we were getting at 2 concepts, would the people respond? And was their blood pressure just really falsely elevated because they were in the emergency department? How much regression to the mean they would have? And that with the main endpoint of our study being how many people would still be hypertensive. And then we found that of our, but approximately 50% of the people were still hypertensive and actually texted us back at least once. So in terms of our main goal, we met that feasibility aim, but we also were looking at what was going on in the dynamics of the blood pressure in the patients who were randomized to treatment versus control. So this is like what kind of happens. They were in this pre-phase, and then they either got randomized to TEX or no TEX, and we got back in touch with the people at 4 months. As you can imagine, the people who weren't getting the routine check-ins with us and the text messaging interventions, they didn't show up to that 4-month visit as often. So that meant we had some more uncertainty in that group. But since our main endpoint was really measured at this point, were they still hypertensive at 3 weeks? The main feasibility arm of our study wasn't sort of dependent on how many people sort of showed up at the end, although that informed how we designed the follow-up study. Another sort of important thing was just how often were people, after they got into the study, how often were they texting us back during the study, in terms of, how many people were texting back a blood pressure over time during those weeks. And this is at the individual level, some people would text them back more over time. And then we did some things looking at how much their blood pressure was changing over time and so forth. But I think the key message was, as I sort of intimated that before, looking at the results in terms of the blood pressure change, we observed a large change in blood pressure. And this was after, not from the emergency department visit, but the follow-up text they did from home to their final visit at 12 weeks. So we saw, noisy estimates, but that were consistent with what we thought would be a clinically meaningful difference of a 3-point drop in blood pressure over time based on the intervention. So that was one way that we approached sizing this trial, but it meant that we made some calls as to, you could say, if blood pressure cuffs are cheap, would you have been satisfied with a 4-to-1 ratio of blood pressure cuffs? Did you want to give them fancier blood pressure cuffs? So you'd be sad if you gave them, the blood pressure cuffs in this study we were using were about $20 US. So if we had decided to use more expensive cuffs, then we would have had less resources to do that. So that was one way that we chose to design this study. But I think, one of the things, Dr. Thabane, that I think is challenging is when you come up with those quantitative goalposts for some of those feasibility arms, they do feel somewhat arbitrary at times, in terms of this many people staying engaged, this many people following up. But I think they're really important because I think I've seen other text messaging studies where the engagement with the individual participants is always seems to be substantially lower than I think the investigators think when they start them. So that's that's something that is I think important to think about. So I guess, how do you come about helping investigators come up with the sort of quantitative bars for their feasibility objectives?
A very good point, Will. It's interesting because when you think about the concept of minimum clinically important difference or effect, It's a concept that has existed for many years, and we still don't have consensus across different disciplines of really what it means and how to get people to agree that, yes, this is the number. It's outcome dependent, it's setting dependent, it's patient dependent. It's never really that easy. So one could argue that even in the concept of how we design main trials, in areas where we have been doing this for decades, we still don't have a consensus. People would argue that, yeah, it's important, but from whose perspective? Patient perspective, clinician perspective, payers perspective, and so on. Now, you can imagine that when it comes to pilot and feasibility studies, coming up with criteria is Wild West, simply because the practice is still at the beginning phase of people paying attention to improve it. We are currently working on some guiding principles of how people need to think about this. But before then, I often advise people to say, just try to be realistic. You know that it's going to cost a lot of resources to make mistakes if you go into the main trial without clear sense of what will work and what wouldn't work. You could pretty much really make every feasibility study successful by setting as low a bar as possible. But that can only be digging in, your own grave, in the sense that if you go in assuming, well, you got success with your feasibility, but that only happened because the bar was too low, then you're going to have more problems in the main trial, which is where more damage is going to be done in terms of wasted resources. So I try to get people to really set, very high bars that would definitely show where the loopholes are. So there is no criteria, but one of the guiding principles is you have an opportunity to really find out what will work, how it will work, and set the bar very high. Even if you don't meet the bar, you're definitely going to learn something about what you will take to meet the bar. So it may not necessarily be that your first feasibility study is the first one. You may have to do the second one because now you've learned something that told you that you need to change something, but that something also need to be tested for feasibility to see whether it will work.
Yeah, to echo what you had said in the prior webinar, the output of the feasibility trial, it's either going to lead you to do the study that you were anticipating for the main trial, modify that and run it because of the things that you learned, or do another feasibility study because you learned key things, or potentially option 4 is to understand that it's infeasible to do anything and really start over with a different concept. And I think the one thing that we sometimes see in terms of these early phase studies is that they gather information, but there's no way that they could give an adverse readout. And in that case, it's a lost opportunity to learn. So if you set all of the bars too low, it's easily seen. And if you know that the study is just going to allow you to move on because all of the bars have been set at such relatively low levels, then you miss an opportunity to learn that you shouldn't do that later, larger trial. So I think I think it's a key point, is there has to be some way that the early phase, and this is I think common to any early phase study, the early phase study has to be able to communicate to you an answer of no, don't go on. And I think sometimes as investigators, we get very enthusiastic about our treatments. It's like, I just need to come up with a design to show everybody else in the world this works. But you have to really look at it from the position of science and say, have I set up the right situations to show that it's possible this would work if tested in an adequate sample size in a future study? And I think, your design has to be able to give you an answer that you can use that isn't just go ahead and do it.
Yeah. Now, if you take this issues to our current situation of COVID, I would say as a community, not only the scientific community, but as a society, we are at a very, very difficult situation where, despite all the best intentions, we are more likely to make more errors than perhaps we intend to. If you think of all the trials trying to figure out what to do in terms of the best diagnosis of the disease. And if we now know somebody has it, they have the symptoms, the best treatment. And then, of course, people are already also going into the best prevention strategy in terms of vaccines. A lot of the things we are trying to figure out is we don't know what is going to work and how they're going to work. So there's a lot of things that we're still learning about the virus itself, let alone now going into designing studies to figure out what's going to be the best treatment. We're still trying to test concepts. How does this concept work? And in many cases, we need to then assess feasibility. A lot of COVID trials trying to assess treatment are just going to fail simply because they never looked into, they didn't have the time to look at feasibility. We still have people who think assessing feasibility is a waste of time. Secondly, the disease is going so fast that even testing feasibility in many cases may not help, right? So there's just so many things we're trying to figure out at the same time that in the end, we're gonna have commit so many errors and waste so many resources at the time when we desperately need any saving we can get, right?
Yeah.
So it's a very difficult situation to think about, but unfortunately we are faced with, you know, despite our best advances in knowledge, we have cases where people are lowering the bar because they're desperate of coming up with something positive. And, you know, even in situations where people think we need to really be assessing feasibility before we move on, they're worried that, well, bring out the concept of feasibility, nobody's going to want to support this because we don't have the time to test feasibility. We just need to go in and treat. Of course, we'll go in to treat, but we may actually make more mistakes, creating more harm than good, despite our best intentions.
Will, it's a real. This is Chris. Can I follow it up with one question?
Yeah, go for it, Chris.
One thing that I wonder if you'll comment on that seems somewhat related to this in general, but particularly in the current environment, is from a scientific communication perspective. I find that a lot of the press, and in particular the public, have a hard time discerning some positive result from a small pilot feasibility study from a positive result from a phase 3 clinical trial, which mean very different things. Like, I mean, just as an example from yesterday, you know, the positive results that came out from that vaccine trial, right? I mean, it was good, but if you looked at the way it was covered in the press, it was way overstated in terms of what it means for the vaccine and it being available widespread. If you didn't know, you know, the research area, you would get the false impression. So I'm kind of curious from a pilot feasibility messaging perspective, what type of advice you might have for you know, for the listeners.
I mean, it's a very good point, but bear in mind that it's difficult enough to train journalists to be able to write accurately about results of scientific studies. I mean, scientists themselves are not trained in how to communicate information to the lay people. Many of us actually do it through trial and error. Yes, of course, we do have scientific writers who do this, but for the most part, those people are not trained specifically how to communicate scientific information in a way that's accurate. They're looking for sensationalization of the information, but that's not the goal of what a scientist would like to get across, right? Now, if you think about the difficulty of communicating the message of what the results mean and what the limitations are, imagine how difficult it would be to try and tell people about the results of feasibility. So we'll say, oh, so what does that mean? Because people tend to think that the message of science or the primary goal of science is to test whether something does more good than harm. So if you're saying, well, no, we first wanted to check whether the main study would be feasible, so what does that mean? And so when are we going to get the answer to the main thing? In fact, I would say, forget COVID. One of the reasons why people have misinformed or failed to provide accurate information about consent in pilot studies is because they say they're fearful that if people hear that it's about feasibility, they may not want to participate. By the way, we don't have any evidence to support that, right? So as a result, the practice of how we get people to participate in feasibility studies is flawed. because it doesn't provide them with accurate information about the nature of the design or the real intent or goal, which is to assess feasibility, while testing whether something does more good than harm is secondary. So it's even more difficult now to try and teach the public at the time when the public is trying to figure out, how do we put off the fire? Don't tell me that you're still trying to assess whether you can use a hose or not. We want to know whether the hose will put off the fire, right? So unfortunately, we're at the stage where it would be incredibly difficult to try and teach people about feasibility and also poorly designed studies that are small sample size, that the message when the result is interpreted is different. Because if it's a poorly designed study with a sample size that is not adequate to address the primary question, the result is not statistically significant, we would say the study is inconclusive. But if it's a pilot study, we wouldn't say the study is inconclusive, because that's a secondary question, right? We're just trying to get a sense of the signal. So the statistical significance is not of importance in a pilot study. We're just trying to get a sense of where the estimate might be, right? So
and I think
yeah,
I was just going to say, another challenge in COVID, particularly like in COVID in general, it's challenging because there's how many patients are going to continue to come in is a completely unknown parameter. And I think that, you know, as our group at Michigan has looked to review protocols, you know, it's tough. I sort of feel bad because they're sort of damned if they do and damned if they don't. If they provide a ridiculous effect size with some prospective benefit, then they might have a feasible number of patients to enroll. But if they provide a more realistic effect size, that I would say, gosh, you know, I would be really happy if we, in severe patients, we would reduce mortality from 30% to 27%. But we're going to need to enroll 10,000 patients worldwide. And I'll be like, I don't know if Michigan's going to be able to recruit 5 patients for this the way things look right now. So we can't answer the question in that way. So it boxes us in on both ends. You know, promising treatments that could make a big difference for a lot of people are hard to test because the studies are so large, and then the patients, you know, the availability of patients are turning down. Smaller studies to answer important questions have to have really, I guess, tremendous biological feasibility to be interesting. Things like direct antibodies and things like that, where I think in cases like that, you know, both the patients and the clinicians can have some possibility of direct benefit, but with, you know, the caveats that it's a really new treatment. Like the first, 12 or 13 people to get a vaccine, as Chris was mentioning, we'll learn a lot from them, and I think there's reason for enthusiasm. But it's not we don't know what things, you know, we don't know what's going to come next.
It's true. Yeah, COVID is perhaps one of the most difficult situations we've ever been faced with as a species, because we're learning as we go along. I don't know if any of you guys have seen the editorial that John Ioannidis wrote at the beginning of this problem, where he was saying that, you know, all countries are introducing serious public health interventions of shutting down systems and so on. And yet, many of the things, while intuitive, there was no evidence in many cases to support that they would do more good than harm. And the worry was that we're dealing with a situation that we don't know how long it's going to last. And we have no evidence that if these interventions were prolonged until God knows when, they would actually achieve the intended goals, or people will start, you know, going in riots against them and then spreading germs even more. And we've seen in cases where this has happened. Right? So.
All right, a couple other points I wanted to make. There was an excellent question about doing feasibility studies in rare diseases and whether, and I think in terms of rare diseases, I would say whether they're chronic rare diseases where you might develop a registry, and then I think figuring out how many people sign up for the registry when there isn't a treatment, but this would potentially give them, you know, give you information about natural history and other things. So I think thinking about that can be important. I also think sometimes doing, you know, a feasibility question in diseases like that are, if I had this treatment that I'm working to develop, would you be in a trial of it? And sometimes people, if there was randomization, would you do it? If people were, say, had a metabolic neuromuscular disease with no current treatment, you know, it's sort of a different thing as opposed to maybe a ALS trial where there's some currently FDA approved treatments. So I think thinking about in rare diseases, you know, having, you know, ideas of registries and asking questions about who might be able to participate, particularly where there's a panel of patients that you may already have from your clinics. And I think, but for new rare diseases that are sort of sporadic, I think the pediatric cardiovascular collapse post-COVID syndrome is another example where intense need to learn more and more about it, possibly initially through you know, some form of a feasibility registry. One other quick question as we're sort of like ramping up to the end that was brought up is one thing to consider for the design of early phase studies are futility designs, in that you're looking for whether or not your treatment effect could lay within a zone that would be promising to move forward. And I think one of the things you can do in the feasibility space is potentially learn what sort of zone you should be using for that follow-up sort of phase 2-ish trial in terms of having a futility analysis. Sometimes though, even in your pilot and feasibility study, you know, you may want to have rules that would tell you, you know, you're already not getting enough text messages returned, so now you ought to, you could stop your study early because you know, you could redesign and do the next and figure out how to retool with the next pilot. So even though they're not always employed in early phase studies, they are a consideration. I think Joy has replaced in the chat box the evaluation form. I really want to thank Dr. Thabane for being on today, and I want to thank you all for your attention, and thanks also to Dr. Coffey, and of course thanks to Joy for organizing and keeping everything moving. Knowing that probably many of us need to be on another video conference call in negative 30 seconds, I think with that I will call us adjourned and look forward to seeing you on future webinars.